So my specialty involves the treatment of cancer patients as well as joint reconstruction. And I think the patient population just spoke to me. It's all ages, it's little kids, it's elderly folks. And I just love being able to help people go through some of those really trying times dealing with cancer. So that's mostly why I picked my specialty.
I chose my specialty, medicine in general, because I enjoyed the sciences. I enjoyed working with people. I went into specifically sports medicine just because I enjoy athletes, playing sports, taking care of athletes, and wanting to get back into all their activities.
And Dr. Sandhu?
In general, I picked orthopedics for a few reasons. One is it's one of the most common conditions that patients are going to face, so I thought it was going to be universally useful. I picked spine specifically because of the complexity of both diagnosis and the surgery itself.
For me, I think with arthroplasty, which is hip and knee replacements, as well as tumor reconstruction, because they kind of go hand in hand. When we remove a tumor around a joint, we have to reconstruct it. The biggest advancements right now are in robotics and 3D printing using robotic assistance, and CT-guided assistance to help with resections and reconstructions, just to be more accurate and be able to preserve function a little bit more precisely than we have in the past. So that's probably the newest and greatest stuff we're dealing with oncology and joint arthroplasty.
As far as sports medicine, there's some newer breakthroughs on cartilage replacements, as far as growing them out and replacing them, along with some newer allograft options or kind of cadaver options for that. In addition, there's some new reconstruction techniques using new grafts. Quadriceps tendon is something that's been used, but it's becoming more popular as more research shows that it's pretty good graft quality. In addition, different techniques to augment the typical ACL reconstruction so it doesn't fail much.
I'll reiterate kind of what Dr. De Comas said. I think image-guided and robotic assistance is getting pretty large in spine, both to help with accuracy as well as safety. I think one of the big things in spine has also been minimally invasive approaches to what used to be large surgeries, multiple inch incisions, a lot of blood loss, a lot of pain. We can do a surgery now in probably half the time, half the length of stay.
So for hip and knee replacements, to be honest, the answer is quality of life. It's when the patient tells me that nothing else is working, they're miserable, and everyone's spectrum is different in that regard. Some people are miserable if they can't play golf every day. Some people will give up golf and be miserable when they can't walk to the grocery store. So for everyone, it's a threshold, and basically if conservative things aren't working, like medication, it's a quality of life issue, and when enough is enough and there's arthritis, then that's the time to have surgery.
Dr. Nguyen?
As far as sports medicine and typically knees and shoulders, as far as the knee, when you have loss of function, persistent swelling that doesn't get better after a few days of rest, ibuprofen, the inability to flex and extend your knee, or the joint gives away. As far as a shoulder, if obviously you can't lift your arm up, then that's cause for concern.
I agree. I mean, if after a few weeks of taking medications you're not getting better, I definitely think you should see a doctor for a more in-depth exam, a more in-depth history, and probably some imaging as well. But for spine specifically, if you're having any issues of shooting pain to the arms or legs, numbness, weakness, issues like that, that might be a more urgent need to come see a doctor.
The short answer is no. Walking is good in general for people as far as a cardiovascular thing, and walking is pretty low impact, meaning it's not a lot of force like running or pounding on pavement that would aggravate arthritis. Activity in itself isn't going to necessarily make, and walking definitely isn't going to make your arthritis worse. It could just make your knee inflamed. The more you do, the more that it could cause some pain, but it's not necessarily going to damage the knee more, if that makes sense.
Okay, and another one for you, is stem cell therapy effective for knee arthritis?
In my opinion, no. Stem cell therapy, and Dr. Nguyen can kind of get in.
So stem cell therapy has been shown to not do any detriment. It just hasn't shown to improve knee arthritis. As far as biologic adjuncts to improve knee pain would be platelet-rich plasma, in which the blood is drawn from your body and it's spun down in a centrifuge, and they take out the good stuff called the platelets and re-inject it into the knee. And that can be helpful, and it has pretty good 1 to 2 year decrease in pain. But as far as stem cells, we aren't to the point yet where it will regenerate cartilage. It has been shown to not cause any downsides, but it just hasn't been shown to cause or have any improvements.
Yeah, and they're typically very expensive for something that really hasn't been shown to build cartilage back.
Generally, I mean, the way we start with sciatica, as long as you don't have any red flag symptoms, such as, once again, weakness or any issues like that, we would start with conservative measures. Probably 80% of people who have sciatica, especially if it's the first time, will get better without doing anything much, mostly conservative stuff like physical therapy and medications. If it's not responding to that, then yeah, injections can help as well. Well, that's a pretty broad question. It depends on what's causing the sciatica. So if it's purely just a tight nerve, either through aging and degenerative arthritic processes, or if there's a herniated disc or something like that, you can just go in there and give the nerve more space by opening it up. If there's a slip in some of the bones in your back or other issues that are causing it, then sometimes you would require some sort of stabilizing procedure like a fusion or maybe even some sort of disc replacement.
So if we're referring to adhesive capsulitis or just generalized stiffness in the shoulder, usually we would recommend either a self-directed therapy program or better yet, physical therapy, so that the therapist can actually lay hands on you and stretch your capsule and stretch your shoulder to make sure you're regaining your function and mobility. There's other techniques called hydrodilation, which is an in-office procedure in which you can inject the shoulder itself and then cause capsular dilation, and sometimes that can help regain the motion without surgical intervention. We recommend physical therapy, cortisone, anti-inflammatories, and if you've had cortisone and that hasn't worked and you've had therapy and injections, then you're probably looking at having a shoulder replacement. And then depending on the status of your rotator cuff, you can have just what we call an anatomic shoulder replacement or a reverse shoulder replacement if the rotator cuff is not functioning well.
Yeah, I think the number one thing you can do is do core strengthening and lumbar stabilization. So abdominal muscles, hip muscles, back muscles all attach in that lumbar spine. So the stronger they are, the more they can take load off that area. Some of this is going to be genetic, so we call back pain is multifactorial. There's a lot of different causes. Some of it's going to be activity, but definitely at least core strengthening and activity will help with those things. Like we kind of talked about, as a person, all you can do is control your activity, control your biomechanics, control how strong your ab, back, and hip muscles are. Beyond that, some of it's genetic, and everyone's going to get somewhere and tear it's natural, but those are going to be the things that you can do to control it.
So similar to all the other conditions we've talked about, physical therapy can be helpful. I would honestly say it's probably the most helpful for mild arthritis. Once it's severe, when people say bone on bone, I don't know how much therapy is going to really help with pain. It can help with strengthening. Cortisone injections do help, and they kind of tend to stop working after some time. So I agree that can sometimes be a short-term solution. There are so-called gel injections, which are really viscosupplementation. It's an option. Again, the science isn't great for them. I think when they were invented, we thought it would build cartilage, which we know that really doesn't happen. But for some patients, it is something that can help and also be a bridge to avoid surgery. Weight loss is huge. I'd be lying if I didn't say that. Definitely that takes force off of any joint and can help with pain. But really, that's about it. If all of those things really aren't working and it becomes a quality of life issue, then that's when joint replacement comes into play. So when we talk about partial and full knee replacements, we're referring to kind of three compartments in a knee joint. You have your medial, which is the inside part, lateral, which is the outside part, and then also under the kneecap. So really to have a unicompartmental knee replacement, that means only one of those three areas can have arthritis in it. If you have arthritis in 2 or 3 or more than one, I would advise for a full knee replacement, because the last thing you want to do is do a partial knee and then suddenly still have pain in the other parts of your knee. So I think that has to be a very careful decision to make sure there's no arthritis anywhere other than that one compartment.
Well, most patients will do well with non-surgical options. So we're talking about physical therapy once again, time, honestly, and then we're talking about medications and injections if your pain doesn't get better with those things. Now, surgical options, once again, comes down to what is causing the stenosis. If it's simply degenerative changes without any instability in the spine, then you can have a decompression procedure, or what's called a laminectomy, just open up the nerves. I kind of tell patients it's like a rotor-rooter for the spine. If there's instability, then sometimes you'll need things like a fusion procedure to hold those bones back so it doesn't keep causing issues in the future.
Depending on how big the meniscus tear is, if it's a small meniscus tear, it can heal itself. But if it's a big one and it's flipped into the joint, then those usually don't heal by themselves. The treatment options for a rotator cuff tear depends on the severity of the rotator cuff tear. If it's a small tear or what we call like a partial thickness tear where it's not completely through, usually it's the typical non-operative treatment modalities such as physical therapy, anti-inflammatories, injections, and activity modification. And if you have continued pain, then we may talk about doing surgery. And then some of the chronic full thickness tears can also be treated with physical therapy and regain some strength and motion and function. As far as numbness in the hands, typically if it's coming from the neck, it goes down to the hands. If they have numbness, usually that stops at the elbow. We say it could be from the shoulder. Dr. Sandhu, what are your thoughts?
Yeah, I mean, it could be a whole slew of things. From a spine perspective, it can definitely come from pinched nerve or even a pinched spinal cord in the neck. It can come from peripheral nerves, which means nerves that branch off later after the cervical nerves come out. So it can come from carpal tunnel syndrome, cubital tunnel syndrome. So there's a bunch of different things that can cause it. If you're really having numbness, you should probably just get evaluated.
Because it's essentially a pinched nerve and it's just where it's getting pinched. So as high up as the neck all the way down to the fingertips. And as Dr. Sandhu said, there's tests. We can do EMGs, which basically test the nerve to see where they're getting pinched, and that can help.
Yeah, so that's just a really complicated way of saying you're getting arthritis in the back. That's how it starts. The disc is the cushion in the front of the back that is between the two bones. It not only provides cushion, but that's kind of where the bones move on top of each other and rotate. So once that starts degenerating and giving away, the rest of the spine starts moving abnormally and starts degenerating. So there's a lot of different treatments for it. Once again, it can cause nerve pinching, or it could just cause back pain, anything from physical therapy to injections and sometimes to surgery to treat it. So ankylosing spondylitis is a condition where you start having inflammatory arthritis instead of just osteoarthritis of your spine and large joints like SI joints, hip joints, shoulder joints. Generally, you're going to start with very conservative measures for this, including physical therapy and possibly NSAIDs or like ibuprofen. A lot of times now rheumatologists will prescribe different medications to try to control the disease process as well. Surgery is not often indicated for this, but if it's a large joint that's being degenerated, you might need to get a replacement. For the spine, Generally, it becomes an issue if your spine gets so brittle and fused up that you can sometimes break it very easily. Sometimes that requires surgery for a fusion. Yeah, definitely. A lot of things can cause numbness on the thigh. Just like Dr. de Comas said, it's just a pinched nerve. It depends where it is. So it can be coming from anywhere in that region, but definitely pinched nerves in the back are probably one of the more common reasons to have numbness in the outside of the thigh, usually the L5 nerve root.
I think you could ask a lot of different people that question and you'd get a lot of different answers. I will typically give injections every 3 to 4 months. If people already have severe end-stage arthritis, injections aren't really going to damage the joint anymore. If it helps, I will do it every 3 or 4 months. I don't know that there's a cap on how many. We just don't know how much steroid in your body is too much steroid. So there are definitely some people that say, I will try 2 or 3 injections if this, if it still keeps coming back, we need to do something else. But you definitely don't want to get too many steroids. So I don't know that there's a true weight cutoff. We use something called a BMI, which takes your height and weight into consideration. And typically, and it's variable, there are some surgeons that will use a BMI of 35. There are some hospitals and surgeons that use a BMI of 40 as an absolute cutoff. And the reason for that is we get more complications. We get more infections, is kind of the number one thing. And so in general, we're trying to not have complications. And we know that if we get patients to lose weight before surgery, we can avoid some of those. So that's where that comes from. So a hip replacement would not help with your spinal stenosis, but I will let Dr. Sandhu.
Yeah, I mean, generally whenever I see someone coming in for lumbar spine pathology, I always do a hip exam on them too, because they often mimic themselves. There's something called hip spine syndrome, actually. So sometimes you'll have both. So the way to figure it out is to get x-rays, imaging, get an exam by a doctor, have a history done by a doctor. And then a lot of times I'll get injections in both to see which one helps more. And then if you have both, you got to figure out treating one, which one bothers you most at the time, and then try to assess the next one.
Some of you may have had that out there, going back and forth between your back doctor and your hip doctor.
But yeah, I mean, doing a hip replacement will not fix lumbar pathology, as Dr. de Comas could find.
And like Dr. Sandhu said, diagnostic injections, you can have a hip injection, and if even just the numbing medicine helps take your pain away, that's going to tell you it's your hip that's the problem. If it doesn't help at all, we might lean more towards the back and actually coming up with the right diagnosis to treat.
I see at least 3 or 4 times a day. Typically, if you have no pain with neck range of motion, turning side to side, and if we bring your arm across and dip it down and that causes your pain, it's typically from the shoulder. Now, if you turn your head a certain way and you feel a shooting sensation going down your arm, then it's likely coming from your neck.
Yeah, I mean, I agree completely with what he just said. A lot of times you'll get numbness and tingling. If you get any symptoms distal to meaning further from the elbow to the hand, that usually is a nerve. The shoulder wouldn't cause pain coming down there. It's just like with the hip, you need a good physical exam, and then a lot of times you need advanced imaging like an MRI or a CT scan to try to help figure out what's going on. Yeah, I mean, it definitely can. It depends where the herniated disc is. If it's pushing on any of those nerve roots too hard, it can cause weakness in any muscle group in the arm. Now, when it comes to headaches, yeah, they're called cervicogenic headaches. Any pathology, whether it's arthritis or pinched nerves, can cause headaches. The problem with cervicogenic headaches is the only way to prove it is to treat the pathology and see if the headache goes away. It could be a lot of things. I mean, it could be myofascial pain just from poor posture, from weak muscles. A lot of people don't work out that area. It can be arthritic changes, so the joints in the back of the neck that get arthritic start to cause pain as well, that can radiate in that area. Or it could be a pinched nerve that can cause pain that radiates into that area as well. Theoretically, yes. Anytime you fuse any joint, it's going to limit motion. It depends on how many you're fusing, and it depends where you're fusing them. So if you're fusing one level in one spot, you probably wouldn't notice that much unless you're a high-end athlete. If you're fusing 10 different levels, then yes, you're going to notice quite a bit. A lot of times what I notice those people is people are in so much pain that by the time you take care of the problem, they actually get more motion because they're not pain limited. So if it truly is just a compression fracture, they're not dangerous. The vast majority will heal without issue within 2 or 3 months, depending on your bone quality and medical comorbidities. The other option for it is called cement augmentation, so it's called a vertebroplasty or kyphoplasty. What we're doing there is you're putting a needle through the skin, it's an outpatient procedure, into the bone where it cracked and it's kind of compressing down just to solidify the area, almost like putting like grout for brick into your bone. It fills up the cracked, fractured areas and it just stabilizes so you don't have much pain.
So we honestly hope they last about 15, 20 years. I will tell you, I say hope because our research lags, right? We only know how long they last of the ones we put in 10 to 15 years ago. And so on average, those were kind of lasting about 10 to 15 years. We're hoping that with newer technology, newer liners that we're using more titanium implants, especially for like hips. We use them now in knees too within the last few years, that the bone actually grows into these implants as opposed to relying on cement that kind of glues the implants in. That was one thing that kind of failed. And then also the plastic that is essentially the cushion in these joint replacements, that wears out. And that's another reason that joint replacements fail. And the better we get at making that stronger, the longer we hope they last. But I'd say on average about 15 years.
Stretching, the same exercises you learned in middle school PE are still effective now. Touching your toes, stretching your arms out, doing leg muscles. Actually, the American Academy of Orthopedic Surgeons actually has a pretty good website that shows some rehab exercises depending on whatever body part you want, shoulder, back, knee. Frequently, I give that out as a reference for the patients.
100% agree with Dr. Nguyen. One thing I also will tell my patients, especially with things like IT bands or bursitis of the hips, sometimes a foam roller is a great thing just to kind of roll those tight tendons out first thing in the morning or whenever you're about to work out. But 100% stretching is going to be a good thing. And if you can do it every day, even better.
Not much more to say. I think they did a pretty good job with that.
So the most typical case for that is what we call runner's knee or patellofemoral pain syndrome. And usually that's a weakness in the quad muscle system, the core system, the hip musculature system. That can be remedied easily with physical therapy, some anti-inflammatories. Some other causes would be some cartilage defects in the anterior knee, or even tendonitis in the patellar tendon or quadriceps tendon would be the typical culprits. Torn ACL doesn't always require surgery. It all depends on what else is torn in there. If it's just an ACL that's torn, then depending on your activity level, if you're very active, if you're playing cutting, pivoting sports, you want to get back into basketball, volleyball, things like that, then the recommendation would be to fix it. If you just like walking, like hiking, swimming, bicycling, you typically would not need an ACL.
There is a lot of research going on into stem cell therapy to try to regenerate discs, but there's nothing really right now that can degenerate a disc. Right now, once it goes, it's pretty much permanent. The main problem with the degenerated discs in the spine versus like a degenerated hip or shoulder, you can replace those. We don't have great replacements for discs in the back, and at that point, the only option we really have surgically is going to be a fusion. Well, most of the studies show that 90% of patients with a herniated disc will resolve at 2 years. So a lot of it's time. You just have to give your body a chance to heal itself, and if you can, you don't necessarily need to do anything. Physical therapy is one, obviously injections like we talked about are one. The problem is not that you have to have surgery for a herniated disc, because unless you don't have red flag symptoms such as incontinence or severe weakness, it's more, can you handle the pain long enough to let your body do what it needs to do? And if you can't, or you need to get back to work, that's when people sometimes have surgery.
So synovial chondromatosis is basically cartilage that's in a joint. So chondromatosis, cartilage, synovial is basically the synovial lining is like the sac that goes around the joints. Every joint has one. And that lining can basically start growing these cartilage cells that float around in a joint, and they can be very painful. They can be diffuse to where there's just hundreds of them in a joint, or there can be a few. So the options depend on how bad it is. Typically, we're doing arthroscopy, where you go in with a scope and clean them out and get all the loose bodies out. If it's severe, sometimes we have to open up the joint, almost like we would for a joint replacement, and actually get all of the synovial chondromatosis out. Typically, Dr. Nguyen will treat a lot of these patients.
I will see them. Very skilled with the arthroscope, so it's pretty easy to go in into all the nooks and crannies in the knee and pluck all them out. It basically kind of, if you ever shake a snow globe, that's what it looks like. You have a bunch of little cartilage things floating around inside the knee joint. And so we have some instruments. We go in or arthroscopically and just shave them all out so that it doesn't catch in your knee or cause problems.
A hip replacement. That's basically it. And it's just like any other joint with arthritis. You could have an injection done typically for a hip replacement, for hip arthritis. My partners that do interventional injections using an x-ray machine would do that so that they know they're accurately getting it in the joint. It's a short-term solution. If it's full bone on bone, full cartilage loss, and people are having pain, then it's a hip replacement. If someone has all those findings on an x-ray and they have no pain and are happy and carry on with their lives, no one's ever going to force you into a hip replacement. The reason to do it is for quality of life and pain.
Generally, that would be more either pain management or physical medicine or rehabilitation. But yeah, I mean, that's a way to try to treat pain that's coming from pain in the facet joints, which is in the back of the spine. It's almost like shingles that each vertebral body kind of sits on top of them. So, generally what they'll do first is give you an injection a couple of times. If you note that numbing that joint actually helped your back pain, then they can go in with a high frequency probe and just burn some of the microscopic pain receptors on those joints. Well, the point of spine surgery is not to relieve arthritis. The arthritis is permanent. The point of spine surgery is to try to alleviate what the arthritis is doing to you, which most of the time, the most successful patients have issues with the nerve or spinal cord involved. So if you have the right condition, then spine surgery is very successful to treat things like that. What we're talking about once again is those little joints in the back of your spine where your vertebral bodies are stacked on each other and they kind of shingle in the back. So if you're having arthritic pain, then that's one of those things where physical therapy definitely can help. Anti-inflammatories, changing just activities. If that's not helping, then injections and radiofrequency ablation are pretty useful for that as well.
So minimally invasive just means small incisions, right? And I feel like that became popular, I don't know, a few years ago. Now I feel like robotics have become a lot more cutting edge, and they're not necessarily minimally invasive in that your incision is only going to be, 2 tiny holes, but it's more precise because you're getting a CAT scan beforehand and the robot is actually helping make these precision cuts. So minimally invasive really just means small incisions, and it's placing retractors where you can actually get visualization and do it through small holes. But at the end of the day, you really need to see what you're doing to make sure that that joint replacement that's being put in is being put in properly. So typically we size them in the operating room. There's a couple different ways to do a knee replacement. We at Core basically all use navigation and robotics. So you're using that patient's CAT scan, or you're using the points that you plot kind of in real time on that patient's knee to calculate a size for you. And there's basically a size of 1 through 10 essentially. And it maps to the most specific size for you. We have them all in the building. And if we're doing robotics, we know the sizes basically before we even get to the operating room for the most part, but we can always tweak them. But that's how we literally measure it off your knee and match it to the size that's made. So if there's a couple types of injections, I alluded to that earlier. You've got the cortisone injections, and then you have the viscosupplementation injections, or people kind of knew them as the, people say the rooster comb cartilage, but now it's synthetic. That is an option for people. That's probably the best person to give that to, because the results are a little bit mixed on that, but if we really don't have an option for surgery, that is something that might help. Again, same stuff we talked about before, weight loss, restricting your activities, doing low impact activities instead of running and squatting and that sort of thing. Anti-inflammatories, such as ibuprofen, Aleve, that sort of thing, if your doctor's okay with you taking those, and exercise and physical therapy.
Yeah, I would also add bracing. You could,
yes,
if you can't have surgery, depending on what the pathology is in the knee or what's going on with it. Sometimes even an elastic bandage or can help, or if you need something a little more rigid, then a hinged knee brace can be helpful too.
Absolutely, and I should have mentioned that. Some literally just give a little bit of support, almost from a mental standpoint, even if it's the elastic, up to some very rigid, long braces that have stays and Velcro straps. Some of those can be bulky, and some patients don't love those, but I 100% agree. They can even make you a custom brace sometimes if the off-the-shelf ones don't fit.
No, so generally speaking, kyphoplasty, at least for the most part, is done in elderly individuals with osteoporosis, so they're fragility fractures. So once you inject that area, that one bone with cement, it's now a lot stronger than the bones around it because the osteoporosis isn't gone unless you've been treated for it. So what can happen is called an adjacent fracture. That can happen in about 15 or 20% of patients. Now, patients who have osteoporosis already have a 15 to 20% chance of risk of another fracture anyways. So the most important part is not just the kyphoplasty itself, is to go in to see a bone health doctor to get on the medications to prevent it happening again.
Yes.
Yes.
Yeah, they work by two mechanisms. You either build the bones up or you prevent the bones from being broken down. And depending on your situation, we have bone health specialists that can kind of tailor a program for you.
We actually have a bone health specialist at CORE, Dr. Crone, who that's all he does is see our patients that have broken their hips, broken their vertebral bodies, and we get all of those patients in to see him because as much as we love doing surgery, we don't want to have people in the hospital with broken bones. So we want to prevent those fractures as much as we can.
As far as collagen supplementation, I know there's vitamins out there. There's no level 1 evidence that says that they work. People may feel, symptomatic relief, and certainly if they do, they can continue using them. As far as injecting collagen into different joints, there's really no efficacy or no real reason to do that. So,
and I don't know much about oral collagen being proven to do much. I think one thing we haven't really talked about is glucosamine chondroitin. There's some sparse literature that says that may help. It's definitely not a harmful supplement, and I usually tell my patients, try it for a month. If you see benefit, great. If you don't, save your money. I have some patients that tell me they feel better with glucosamine chondroitin. I don't know if you have any.
Yeah, that was about 15, 20 years ago. That was a rage to put everybody on glucosamine and chondroitin sulfate. I think the last large series I've seen was that showed it no difference really.
Yeah, so it kind of depends on what the problem is. If it's a purely nerve-related issue and there's no instability in the area, you can just do a decompression. So you just open up the nerves by removing some parts of the spine. If there's instability or severe pain, mechanical pain from the motion at that segment, then sometimes that requires a fusion. The way you do fusion is multiple different ways. You can go in from the side, the front, the back. The point is just how you're getting it fused to stabilize it with screws and rods, and sometimes cages.
So that is the way you put a hip replacement in. So the traditional way has been kind of a posterolateral approach, meaning kind of over the butt or kind of over the side. Anterior approach is exactly what it means, on the anterior part of the thigh. Two different ways to get to the hip. It's the same hip replacement once you're putting it in. There's risks and benefits to both. I think anterior hips became quite popular because it was a thought of, do we get patients up quicker doing this? Because we're going between two muscles as opposed to going through one larger, the gluteus in the back. I think honestly, the literature now is showing that we're pushing our patients to get up and get going, get home the very next day, some the same day now, no matter what approach. After a few weeks, there's really not a huge difference, and even after 6 to 8 weeks, studies show there's really no difference in long-term outcomes, and even our short-term outcomes are very similar. And so it's really a preference of the surgeon, of the patient. I don't do the anterior approach. I have a couple partners that do. It's what you're good at and what the patient's comfortable with. But it's just a different way of getting to the hip joint.
Yeah, definitely. I think we, in general, used to do a big open posterior, meaning the back of the back. We would open it up and put in a lot of screws and rods, and sometimes have to break bones to realign them. A lot of times now we can just make small incisions in the side or in the front and put in cages to kind of help push the spine back to where it needs to be. And then you can place screws through kind of small poke hole incisions in the back. Once again, using some things like X-ray, robot guidance, sometimes CT guidance in the OR. You can't necessarily use a test to diagnose nerve pain. You can use it to test for the health of the nerve. So it's just measuring how quickly it conducts its signal across itself. So that would be an EMG or nerve conduction study. Now, if you're having nerve pain coming from the spine, we usually get MRIs of the neck or the mid-back or the low back to see if there's any area where the nerve might be pinched. And we use injections all the time too. We inject the spot and see if the pain goes away to help us find out if it's coming from there.
So a partial hip replacement, and I hope I'm going to answer this correctly. You'd assume like a hemiarthroplasty? Yeah. So hopefully I don't get too long-winded. A lot of times when people talk about a half of a hip replacement or a partial hip replacement, it's after someone breaks their hip. It's usually elderly folks that we're not worried about putting a liner and cup on the actual pelvic side. We're putting just a big ball that sits in that patient's socket. It's a quicker surgery, get them off the table after they break their hip. Back in the day, we used to do more hip resurfacing, where instead of replacing the whole ball, which we usually cut off and put like a ceramic ball that sits in a cup, they would just put like a metal liner on top of your bone, kind of core it out, and do what we call a resurfacing, not replace the whole head. When metal on metal kind of fell out of favor with all the problems we had, as well as leaving some of that bone behind, you can actually break your hip when you do a resurfacing. They've really kind of fallen out of favor. So I think for arthritis of the hip, if you go in to get an elective hip replacement done, you're going to get a total hip replacement done. When I think of a partial hip for a hip fracture, that's also very common. But there's really no kind of partial hip replacement like there is for a knee, where you only do part of the knee, if that makes sense.
Yeah, so typically the partial hip replacements are reserved for the trauma setting in which somebody breaks their hip.